Welcome to the recorded version of Hospital and Home Preparation for Seniors, part of the Family Caregiver Support webinar series brought to you by the American Society on Aging and a generous sponsorship from Home Instead Senior Care.
Our presenter today is Dr. Amy Dupree, a gerontological social worker who is an internationally renowned expert on lifestyle issues relating to caregiving, retirement, aging, and family dynamics. Dr. Dupree is president of Essential Conversations, Inc. and Dr. Amy, Inc., a company dedicated to family caregiver wellness. Dr. Dupree holds a PhD and master's in social work, specializing in gerontology, and she earned her CSA, a designation for which she also trains others as part of their accreditation. Dr. Amy Dupree is a much sought-after speaker at corporate and professional events on the topics of caregiving, aging, and retirement, and she's also a frequent guest on radio and television. And with that, I'd like to welcome our presenter, Dr. Amy Dupree. Welcome.
Thanks, Steve. I appreciate it. And let's jump right into this one, home from hospital. And today what we're going to do is we're going to talk about what we as professionals can do to help people being discharged from the hospital so that they make a successful transition back to their home and to their community, and hopefully so that they can avoid being readmitted whenever possible. I'd like to review the reasons people are readmitted to the hospital as a starting point so we kind of can talk about what's going on and what's not working and what is working. And then what we can do is focus on what we as professionals can do to be part of the solution and really help minimize the number of readmissions. So let's start by taking a look at the high rates of hospital readmission. Now, this isn't a new thing, and this is a Robert Wood Johnson Foundation report that I'm drawing from here, which is called the revolving door. And this is, as you know, been a challenge for decades, getting people to not end up being readmitted to the hospital. This is according to an analysis of Medicare data that was done by the Dartmouth Atlas Project, and this is what was published by Robert Wood Johnson Foundation in that report. And that came out in February of this year, so this is very current. And what we can see is there's really been very little progress when it comes to reducing readmission. So overall, improvement has been slow and inconsistent. That's what the report writer said, and you can see this in the table. If you look, you see the readmission rate for Medicare patients in hospital from a medical condition, as opposed to surgery, was 15.9 in 2004, and that's exactly what it was in 2010. Now, just in case you're wondering or don't know, CHF is congestive heart failure, AMI is acute myocardial infarction. So if you look at that chart, you'll see, almost no change, yet it's something that's being talked about quite a bit. So let's take another view of that, which is looking at readmission rates by area, because this is pretty interesting. So I think it's pretty interesting to see how readmission rates vary across the country. The Dartmouth researchers found that people who had similar illnesses have very different odds of being readmitted depending on where they live and on what hospital they go to. Probably doesn't surprise any of you because I'm sure you know in your regions it's different hospital to hospital. But for example, looking at this, the readmission rate for patients who were discharged after a medical admission in 2010 was 18.1% in Bronx, New York. But when we look in Ogden, Utah, it was only 11.4%. That's a huge difference. The geographic variation was even greater for patients who went to the hospital for surgery. So 18.3% of Medicare patients from the Bronx were readmitted within 30 days, compared to only 7.6% in Bend, Oregon. So according to the federal government, almost 1 in 5 Medicare patients is readmitted within 30 days of discharge. And the cost of that is $26 billion each year. So of that $26 billion, what we have to say is what's avoidable. Well, what the estimate is that $17 billion is spent on readmissions that are deemed to be avoidable readmissions. So just imagine for a minute what we could do with $17 billion freed up every year. It'd be incredible. And certainly as we see the population aging, if we don't deal with this issue, that figure will continue to grow. Okay, so why is this going on? Let's take a look at that. So why is it that so many people end up back in the hospital within 30 days of being discharged? Obviously, this is complex. It's not a simple answer, and it isn't just one answer. And as I mentioned, not all readmissions are avoidable. some people actually go back for a scheduled treatment. So they're, going back in, the readmission is something that is on the radar and they're scheduled to do it. Some people are 2 a week when they're first admitted to have all the treatment that they need, and so then they have to go back for what they didn't get done the first time. Others are discharged for one condition or illness, then they go home, and then they have something new crop up. So as an example, a friend of mine was discharged after having hernia surgery, but ended up getting readmitted a few days later for pneumonia. Completely different and not related to the hernia surgery at all, which was a quick overnight. So many patients are readmitted simply because they live in an area where hospitals are used more frequently as site care for illness. Rather than going to the doctor, people go to the hospital and then they get admitted, and that, of course, leads to both higher initial admissions, and it also leads to higher readmissions. So those are some of the complex reasons, and again, not all of them avoidable, but many are avoidable. So let's take a look at that a little more deeply. So what are the problems that we're seeing that lead to the avoidable hospital stays? And so what you see on the screen is the words of Dr. Risa Leviso-Moray. She's the president and CEO of the Robert Wood Johnson Foundation, and she wrote the introduction to The Revolving Door, a report on U.S. hospital readmissions. And what she has said is that people are being readmitted as a result of a fragmented system of care that too often leaves discharged patients to their own devices, unable to follow instructions that they never understood, and not taking medications or getting the necessary follow-up care. So those are pretty serious issues. So let's take a look at some of these drivers that the report talks about and what could be done about that. So when we look at the drivers, many patients are discharged, as we said, without understanding their illness. And when we look at this from the standpoint of chronic conditions, things like diabetes and heart issues, this can really pose a particular challenge. And that's because a lot of times the staff may think that the patient already knows how to care for this condition since it's a chronic condition. So this situation emerged with two patients that were mentioned in the study. In that case of the study, both of them had diabetes, and neither of them had a clear grasp of what their diet should be, how to adjust their insulin levels, or how to inject the insulin. But again, the staff thought they did. And let me share with you one story on the next slide. This is a woman named Barbara, and you can hear how this worked for Barbara. So Barbara is a white 44-year-old woman. She lives in the Bronx in New York City with her husband and her 4 children. She's worked as a child care provider for the last 10 years, and she has a lot of health issues. She has type 2 diabetes, and she says it's caused nerve damage and constant pain for her. She also suffers from other conditions, sleep apnea, high cholesterol, and thyroid disease. So although she was diagnosed with type 2 diabetes in 1998, this is a long time ago, you can see, she still has gaps in her knowledge about how to manage the diabetes. And this really came to the forefront when she was hospitalized about a year ago. She said that not once did she recall having a serious discussion about her diet with her primary care provider. So that must have been over all those years she never had a serious conversation with a provider. She went to the emergency room when her blood sugar reached 500. She said she didn't call her doctor because it was late in the evening and she figured he wouldn't answer. So Barbara ended up admitted to the hospital. She stayed for 2 days. She said that doctors in the hospital gave her saline through an IV. They gave her insulin. They put her on a diabetes meal plan. They took her blood sugar 3 times a day, so her blood sugar count. So obviously, she's getting good care in the hospital around this. And then her primary care doctor visited her during the hospital stay. Her emergency room doctor actually had asked who her primary care doctor was and contacted him. And the primary care doctor told Barbara to make an appointment once she was discharged so that they could develop a new care plan. So, if you look at it from this standpoint now, everything seems pretty good. But after 2 days, the doctors felt the count was pretty stable. They discharged her. And Barbara was still questioning whether or not she should be discharged because she said that the discharge process from the hospital wasn't really very detailed. And she explained that the hospital doctor stopped by her room and just said, watch what you eat, and everything's now under control. It's safe to leave. A nurse gave her a little more detail, things like, no sugar, no soda, no candy, no sweets. But what Barbara really wanted at this point was more information and maybe to speak to a nutritionist. But she trusted her doctor's opinion that she could go home, and she did. Now, when she got there, remember, her primary care doctor said, call, make an appointment. So she did that. She called to make the appointment, and she was told that the earliest opening was a month away. Now, think about this. She'd been in the hospital in a pretty serious state, and now she's being told you have to wait a month to get in to see the doctor. And when she told them, look, I just got discharged from the hospital, they said, I'm sorry, there's no other appointment available. So she was pretty good in the beginning. About a day and a half, she did okay, and then she started having terrible headaches. And when she checked her blood sugar, she found it was 700. As you can imagine, that's when she panicked. She knew it was dangerously high, and so she had never seen that before and didn't know what to do about that. So what she did was she hopped in a taxi and went straight back to the hospital. The second hospital stay lasted 2 weeks. During that second visit, she was given a new kind of insulin. Her doctor told her that her body had become accustomed to the old insulin and that she needed to change the dose. And then the hospital doctor also recommended she started seeing an endocrinologist since she had all these multiple health conditions, not just the diabetes. No one had ever told her that before. That was the first time she had that kind of care. When she was in the hospital, Barbara also met with a nutritionist, something she'd wanted to do during that initial visit. And she learned during that consultation that many of the food she was eating were bad for her, like white rice, which she thought was a grain and was good for her. She found out was actually a bad thing with her diabetes. So after the 2 weeks in the hospital, Barbara was feeling better and ready to go home. Once she got home, she finally had the appointment with her primary care doctor, and it was the primary care doctor who taught her how to adjust her own insulin amounts. He also instructed her how to correctly inject the insulin. And she thinks if she knew that information before, she probably could have avoided the hospitalizations. So let's take a look at what Barbara said about this. She said, I would have liked it if they told me what I could do better to take care of myself, because maybe I'm doing something wrong. Sometimes I might skip meals, and then when I do eat, I'll eat all the wrong things. I would have liked to maybe speak to a nutritionist, something like that. And when you see that, we can see that Barbara's story really provides us with a great example of how a lack of understanding of her condition, of the steps she needs to take at home, about diet and exercise can lead to readmission. It also points to the next driver of readmissions, and that has to do with the appointment with the primary care clinicians or with specialists, and the fact that that often doesn't occur soon enough after discharge. Without the clinician visit, an opportunity may be missed to recognize the patient is not improving or that the patient has backslid in some way. In Barbara's case, her primary care physician was notified and in the picture, but there was no opportunity for the fast follow-up. So information about a patient's hospital stay does not, however, always go to the appropriate doctor. So in this case, it wasn't an issue. He was involved from the start. But sometimes the doctor doesn't even get it, and that's another issue. Okay, so now let's look at the issue of medications in this. So we're starting to hone in on what some of these issues really are that are getting people back in the hospital. And I'm guessing the story that we just talked about with Barbara is probably a story that many of you know in some other format, that you know someone who was in the hospital and they got discharged and there was care that wasn't followed up on, there were instructions they didn't understand, and then they end up in problems. So in Barbara's story, we can see that the medication definitely played a role in the readmission, and that's not unusual. Sometimes what happens is patients inadvertently discontinue important meds that they really need to stay well. Sometimes they may not have the right prescriptions or be able to fill them, and sometimes they're confused about the medication. And I know as my father especially was aging, and he was he was cognitively intact. He was a bright man. He understood things. But managing the medications, even in those cases, was very, very difficult for him. And often it was because he was hesitant to ask the doctor a question, or there wasn't time to ask the doctor a question, and he felt the doctor knew what they were doing. So maybe a medication is changed in the hospital, and the family physician isn't even aware of this, and then they prescribe another medication that conflicts with that medication. And this is a pretty common issue that happens. And I just saw this recently with an older person who had been prescribed a drug for acid reflux, and it interfered with another drug that the doctor, when they got home, got prescribed, and they ended up having a terrible reaction to this interaction and ended up back in the hospital because of it. And it was truly a lack of communication with the medical staff about what was going on. Another communication is that patients can become confused when medications are changed and the change isn't clearly explained. So there was an oncology nurse in Washington, D.C. that said, we sometimes prescribe warfarin and sometimes we prescribe Coumadin, basically the same medication. And sometimes patients get these medications listed on their medication files. So when you have a patient, they may think that the warfarin and Coumadin are completely different, so they take one of each. And as a result, they have an adverse effect from the drug. So I think that quote that you see on your screen is pretty key because it goes back to, again, the fact that oftentimes there's not enough time spent with people and there's not an understanding of what they know and don't know, and this is a big problem in discharge. It's also a big problem with our older population because a lot of times still the older are very hesitant to ask questions, and they may not be getting the information that they need, and it could be because of a hearing loss. It could be a hesitancy to ask the questions, and so then they get discharged with this drug, and they may be taking the wrong drug or the wrong doses. So this idea of communication is key. Okay, let's look at other drivers that can get in the way. Sometimes it has to do with family members are not included in the discharge planning, even though they may be the central caregiver and managing the overall care. Obviously a big problem. So we keep coming back to coordination and communication as two of the major issues. Sometimes the physicians caring for the patient don't communicate with each other, and then they fail to develop a coordinated plan for post-discharge care. According to the revolving door study, most important is the lack of clarity regarding the clinician who's responsible following discharge. In addition, other issues are accountability that's scattered among hospital staff, community physicians and nurses, the skilled nursing facilities, and family. So you have this often group of people who are involved in care, and there's no clear accountability, and there's no clear central person to go to. And without that clear accountability, problems that are very likely to have been prevented get missed, and then it leads to the emergency room visits and repeat hospitalizations. And again, the fact that patients are often embarrassed, and so they're not as honest as they should to say they don't understand the directions, that can be a big problem as well. Okay, so before we move from this section, let's take a look at the summary of the drivers. So here's a recap of all the issues that can cause readmission. And these are, again, from the revolving door report and speak to the patient's perspective. Many patients said they felt they were discharged too soon. And again, I'm sure that's not surprising to any of you because this has become an increasing issue over the last couple of decades that people feel that they are discharged sicker and quicker. Some of the patients who were interviewed believe that the timing of their discharge was motivated by the hospital's financial concerns. So that is very frustrating to patients. However, a few wanted to be discharged and didn't resist, even though they really knew that they were too ill to be home. So the issue isn't always the hospital's fault. Sometimes it's the patient's fault in wanting to get home. Many said they didn't understand their discharge instructions. They felt tired. They felt afraid. They felt that they were, this is a quote from the report, in an alien world in the hospital. 15 minutes of care instructions and pamphlets about their illnesses were not enough. So again, when you look at chronic conditions, people often need more education than that. Just saying to them, this is how you manage, as we talked about with Barbara, don't eat these foods, do this, really doesn't give the patient enough time to be educated in the way they need. We know that those who saw a nutritionist or a physical therapist, those who had more time with the doctor or the nurse during discharge, seem to do better. So this time factor really, really makes a difference when we talk about discharge. A lot of times the care instructions were just too general. In some cases, discharge instructions lack the detail both the patient and their caregiving family member needed once they were home. So they got home and they're reading the discharge instructions saying, I don't really fully understand this. Some of them said they wished the nurses had told them more about what they could eat, what they should avoid, how to sterilize cloths used to clean an incision. things like how to inject insulin and what the risks were if they stopped the medication. Patients and caregivers also wished they had been more assertive. A number of times during the interviews for this report, a patient or caregiver would say, perhaps I should have asked more questions. But again, as professionals, I think this comes back to us saying, how do we make sure we're creating enough space for people to ask questions? You know, making sure we check in and say, does that make sense? I want to pause here and give you a moment to think about that. Although the patient said having a family member or other caregiver present during discharge made a big difference, they also said that wasn't the solution, that they felt they needed to be more aggressive themselves in asking questions and pushing for details they needed once they got home. And again, I know many, especially older people, feel much better when a family member comes with them and there are two people to hear all of the details. It can be very overwhelming to absorb a lot of information at discharge very quickly. Now, new diagnoses really had special challenges attached to them too. So one patient was diagnosed with COPD during the initial hospitalization and was completely overwhelmed by getting that diagnosis. So just simply the fact that getting the diagnosis would kind of shut him down from being able to hear the rest. So then he said he wanted more information, more one-on-one time with his doctor, he wanted more hands-on training, and he wanted more follow-up care, none of which occurred. Sometimes, as you see in number 6, the primary care physicians are missing from the picture. And this is a problem if they've been following the person for a long time, know the history, and understand what's going on. And then in a number of cases, the patients left the hospital, and they weren't seen by their primary care physician or their regular specialist. They gave a number of reasons for this, but lack of oversight by their own physician seems to play a role in some of the readmissions. So again, we have a communication issue and a role issue going on here. Once they got home, some of them didn't have very good supports. Many of the patients in the report were single or divorced men who returned home alone and just too weak to even take care of themselves. Some of them were not ready to change behaviors. And again, this is another patient issue, not the professional staff issue. There were 2 patients in the study that admitted they didn't comply with the care instructions once they left the hospital and that they went back to engaging in behaviors that put their health at risk and perhaps trigger the readmission. So again, a patient who was hospitalized for COPD started smoking again soon after discharge, but argued that he was addicted to the cigarettes and that his hospital provider should have given him more support to quit smoking. So whether or not that is patient, hospital, or a combination, certainly there's something going wrong there. And then if you had chronic health conditions for years but hadn't been educated about their illnesses, a number of the patients in the study had been battling their chronic condition for a long time, things like diabetes and heart disease, and yet they still didn't have information about how to care for their condition. If they did receive it during their initial hospital stay, then they went back to their unhealthy behaviors once they were home, and that again caused the readmission to occur. It was found that if their doctor was affiliated with the hospital, the outcomes were better. In some stories, it seemed to matter if the attending physician was affiliated with a hospital or part of an outpatient clinic connected with a hospital. When there wasn't the affiliation, some patients were confused about follow-up care and who to go to when they became sick at home. And I think that's understandable if we think about the fact that people may be seeing multiple doctors while they're in the hospital, and they don't know who it is they're supposed to be responding to and following up with. It's a big issue. Okay, so let's take a look now at the fact that the revolving door report, which we've been looking at here, was launched in tandem with a new initiative, which is called Care About Your Care. And if you haven't already seen that, I want to encourage you to check it out. And it's one of our resources today, Care About Your Care. I have to tell you, I'm actually heartened and inspired by the number of projects taking place across the U.S. that are hopefully going to help avoid these readmissions. And we can't avoid all readmissions, but we certainly can reduce the avoidable ones and start to try to look at, is there any way to intervene in the ones that we've deemed to be unavoidable? It's a pretty exciting time because this is being addressed head-on, and I think ultimately it's going to be good for the patients, it's going to be good for us as professionals, and certainly for those of us in the future who care about these things, it's going to be important. Okay, so now let's look at what we can do as professionals. here's the care about your care information. So you have that there. And again, we'll give it to you in the resource area again. But it's worth getting on and taking a look at this about how to improve the transition, how to reduce the readmission. And you can see it's a national conversation that we're talking about that's going on, and a very exciting initiative that's happening. Okay, let's take a look at now what as professionals that we can do to reduce the need for readmission. And what I'm going to do is I'm going to share this with you from the perspective of the patient and the family. And what we'll do in the next few slides is I'll talk to you about this, about what we as professionals can encourage families to do. So it's going to be directly for the families and how do we relate to them. So what we know is that planning for a smooth transition back home really begins as soon as the person enters the hospital. So getting prepared means that people have to ask a lot of questions. And this is likely the patient and their caregiver in consultation with the medical team. What they need to do is to try to determine things like length of stay, extent of illness, what the patient will or won't be able to do when they get back, dietary concerns, medication that might be needed at home, is there follow-up care required at home, warning signs, and any warning signs that something's going awry and they need to come back or need to contact the doctor, and then help that potentially may be needed short and long term. Now let's just stop and talk about this for a minute, because if you've ever had a family member who was discharged from the hospital, you will know getting these questions answered is not always easy. It's hard to get everyone on the same page to give you the answers you need. I know with my dad again, he was admitted 2 or 3 times in the last year of his life to the hospital, to a rehab facility. And because I've been in the field so long, I knew to start asking questions. Do you think my dad will be able to go back to his house? Are we going to probably need 24-hour care? My father had an ostomy bag that was an issue that in his last year of his life that needed care. And was he going to be trained to be able to do that, or was I going to need to hire someone to do that? And I found it was very hard, not because the staff didn't care. They were often running around overworked, too many patients, and not enough coordination internally for them to be able to answer those questions. So I think we really have to say to families, these questions are imperative to get answered, and it may not be easy for you to get them answered. Okay, the other thing that people have to inquire about is insurance coverage and where to find the resources they need, because it's great to say they need help either short or long term, but if they don't know how to access the resources, that becomes a big issue. Okay, now let's talk about the caregiver and what they can do. So once the caregiver has the information that we just talked about in the last screen, then they can start to move into making the necessary preparations for bringing the person home. So we can talk to them again about what they need to do once they have this. Do they need to get medical equipment? Do they know where to get that? Having it delivered? Do they need to talk to the pharmacy about medications and perhaps getting some help with managing and coordinating the medication end of things? Are there safety issues in the home that need to be dealt with given the change in the person's condition or what's been recognized? What needs to be done there? Obviously, there are probably going to be follow-up medical appointments, and we need to then look at how are they going to deal with that? Is there someone who can take them? Is it them? Or do they need to arrange some follow-up rides? They need to look at stocking up on healthy foods, making sure that all the things are ready at home for when somebody comes home from the hospital, such as making sure there's clean linens on the bed, and is there, if there's a new hospital bed, that there are appropriate linens for that bed. So there's a lot of work that caregivers have to go through in preparation for getting someone home. And the issue with this is that, as we know, people often get almost no warning that someone's coming home. This is why we're encouraging you to talk to families about getting questions answered ahead of time. Now, some things aren't known until very close to the person gets discharged because conditions change and things happen. But some of the questions can be answered very early when the person first gets to the hospital. And while the person's in the hospital and there's not yet a plan for discharge, the caregiver can start dealing with some of the issues that need to be dealt with at home. Okay, now let's talk about home care. We know that for most families today, both spouses are working for pay outside the home. This means that depending on the situation with the person coming home, they may need to hire outside help. So we know that home care companies can assist with a number of different things, and you see them on your screen. They can help with the discharge coordination. They can help deal with the medication issues, the follow-up doctor's visits. They can help with the cooking of meals, with shopping. They can also be the ones who are monitoring warning signs that something might be going awry, and that's why it's important to have them involved in what's known about the condition, what's known about the changes, so that they can do this kind of monitoring. They can also keep records about what's happening in the person's life. So things about, blood sugar levels, making sure if there's any sort of an issue around heart conditions and medications and how the person is behaving on that. All of those sort of things are important. And then, of course, transportation. Home Instead Senior Care offers a specific service, and it's called Hospital to Home. And it's specifically to help people make this transition. So if families arrange for assistance to help with your with the older adults' activities of daily living, such as bathing, dressing, eating, taking care of the household tasks, it's really important to get regular progress updates. So the family can't step away, but they can partner with the home care company to make sure that they have the information they need to monitor their parents' condition. This way they can determine if less or more help is needed and to make sure that their aging parent is doing okay. I had home care in with my parents almost the whole time that they needed care, and we acted as a care team that worked very well. I would ask them to keep records. I'd check in with them. They'd go back and read me things and say, well, this is what happened yesterday. And it makes a huge difference in assessing whether things are going well or if things are starting to turn in the wrong direction. We know that nutrition management is a really key part of keeping people healthy. We know that with some illnesses, if someone's had surgeries, if they're on certain medications, they can lose their appetite or food can taste off. And the problem with this is it means that they may not get proper nutrition or they may not be properly hydrated. And this is a big problem. So warning signs to look for that we can share with families include depression, weight fluctuation, lethargy, skin tone, and frequently cognitive issues, the confusion that comes along with dehydration. Now, I'm watching this happen right now with someone that I know well whose parent is having some significant issues around nutrition management because she's lost her taste for eating and she's having some problems with her spine that it's very hard to swallow. So she is losing weight rapidly, and they're trying to figure out how to manage this and keep her hydrated. And that's really something that has to be checked in on a daily basis. Nutrition is not something we know that families can wait a long time to deal with. It's an ongoing issue. Now, one of the things that can happen that can make this better around nutrition is to make meal times a time for social interaction. And in that way, it often helps a person eat more and get the nutrition that they need. Another strategy is to prepare meals and shop for the healthy ingredients ahead of time so that when someone needs a meal, it just needs to be reheated or it's available with simply prepared foods, and then there isn't the big issue about making sure at every specific mealtime that there's something there. There could be a couple of days' worth of meals in the refrigerator, but this idea of making sure that there's enough healthy food in the house is a really key one. Okay, so that's some of the issues that we know families and caregivers have to look at. Let's take a look now about what they need to do when the person is leaving the hospital. So what we've talked about up to this point is what has to happen before they leave the hospital. And this is now the patient's about to leave the hospital. Either they themselves or their caregivers have to ask a number of questions. And again, you see these on your screen. What medical conditions do I have? This may seem like a silly question, but a lot of times people aren't really clear what their diagnosis is and what are chronic conditions and what are not. The idea of making sure they have all the medications they need listed out and that those don't interfere with any of the medications they're currently on. Looking at what else they need to do is a key issue. Whether or not they need to follow up with another healthcare provider. Do they need to see a nutritionist while out of the hospital? Do they need to go back to their primary care physician? Who is it that they need to see? And then asking if all the doctors have the discharge plan, which is very, very key. And then probably the most important question on this page is, whom should I call if I have questions or problems? Because what we know is that when people get home and they don't know who to call, their next thing that they often do is to go right back to the emergency room when it could have been avoided if they could have called someone. Okay, so now we've gotten them through the discharge process. Let's talk about getting them actually back home. The first few days back at home are the most critical, and that's why we need to focus on that to start with. This is, first of all, where people need to watch for the warning signs that something's going wrong. It's also a great idea to keep the daily record of medications taken, meals eaten, activities undertaken, and any assistance that needed to be provided. Because if you look at this, if the person does end up going back to the doctor or to the emergency room, they now have all the information they need. For caregivers, it's really important during that first 30 days to make sure that their family member keeps all the follow-up doctor and rehab appointments. In addition to checking progress, those appointments are very critical for things like the prescription updates if they need more prescriptions, blood tests that they may need to have done to reveal anything that's kind of hidden. Might be that they need care for wounds or incisions. They might also need follow-up X-rays or CT scans that make sure everything is going right and staying on track. Another very common concern for older adults and their families is making sure they have transportation to get to those appointments. So it's key for the caregiver to think about this, as we said, ahead of time, but then again, once the person is back home, to say, do they need help from a local service agency that provides this kind of service, or for home care provider to make sure they can get back to the appointments that they need to get to. Okay, now during the first few days after returning home, let's take a look at some other issues. These are some of the warning signs we know that people need to look for and to make sure that they call the family doctor if any of these happen. So you can see a list of them here, and these are very key things to make sure that your families and older adults know. It's a great list to say, okay, if something does go wrong, do we know when to call? And these are some very, very important reasons to call quickly and not to wait. And then you can also see a list here of reasons to call 911. It's amazing to me how frequently people hesitate to call 911 when there is a serious symptom going on. I, in the last 2 months, have lost one of my dearest friends who they did not call 911 when she was having a heart attack. Now, whether or not she actually would have survived is unknown, but her husband waited and tried to get her to the hospital on his own. And I think we have to continually reinforce with people that if there are any of these kind of symptoms, they need to call 911 and not try to get themselves to the hospital, because the delay in care can be significant, and it's possible that the emergency team that comes out may be able to deal with it, and certainly will have communication with the hospital to be able to try to treat them and prepare the hospital for what's happening when they get to the hospital. So I think as professionals, one of the best things we can do is continue to tell family members, do not drive someone who's having an emergency to the emergency room. Call 911. That's why the service is there. And a lot of times it's the patient who will say, no, I'm fine, don't call. And that's one time that I encourage family members to override, because it's a safety issue. And when it's a safety issue, we really, really need to deal with that. So this is, again, a key sheet that I want to call your attention to, because I think it's important for us to share both of these columns with family members and with the patient, so that there's no question about when to do this. Okay, so let's now talk about some of the resources. As I mentioned to you, there's the Care About Your Care. There's the Robert Wood Johnson Foundation. Those are both excellent places to look for some of the information I've shared with you today. Obviously, there's even more in those two sources. And then on the Home Instead Senior Care sites, caregiverstress.com, and the site that specifically deals with this issue is called returninghome.com. And it talks about how we can really start reducing these unnecessary readmissions to the hospital, and how, as professionals, we can start intervening to help family members have a better experience, because we know that people, when they get home, do not want to go back to the hospital. That's the last place they want to be. Okay, let's talk about some next steps and where you can go from here. So there is a tip sheet on what families should watch for, and you can reference that and you can give that out. And Steve's going to talk to you about how you can get a copy of that tip sheet. It's available to all of you, and it has a lot of this information summarized on it, including it has information on what patients need to know when leaving the hospital, what caregivers need to do once their loved one is back home, and that information we just talked to you about when to call the doctor and when to call 911. The other thing that we can do is offer information that will help people avoid readmission and stay healthy. So you heard a lot of things today about the issues that are going on that really we could help intervene with. We could teach family members to ask more questions as well as the patient. We could tell them that they need to watch out for these, certain issues that are likely to come up. We can make sure that caregivers are prepared before the person comes home by buying the equipment that's necessary, by making sure they understand the care plan. And certainly we can encourage the older adult and their family member to talk with the doctor before they get home to make sure that there is a follow-up medical plan and that everybody needs to know who to call if something goes awry. You might want to also consider reading the Revolving Door report. It's an excellent report. It's really worth the time reading because it will make you much better educated about this issue, and you will see the places where you can intervene in it. And then, of course, I want to encourage you just to share resources that will help people, with issues around their physical condition, what they're going through emotionally, all those sort of things. Anything you can provide that helps with strengthening that will certainly help prevent people from being readmitted to the hospital unnecessarily. Okay, I'm going to stop now, and what I'm going to do is I'm going to turn this over to Steve, and Steve is going to open up the phone lines for questions. Steve?
Great. Excellent presentation, Dr. Amy, as always.
Thank you. It's chock-a-block full of information today, and I think information that's really useful for those of us who are working in the field to step back and say, wow, how do we shift this picture? Because it doesn't have to be this way. We can really help a lot of people not have to go through this. And when you think $17 billion is a lot of money that we're spending unnecessarily.
Okay. First question for you here. I work with clients whom often don't understand the difference between avoidable readmissions versus unavoidable readmissions. How can I easily differentiate these two?
Well, I think the avoidable readmissions we can look at and say, if there was something that we could have done to prevent it, that's the problem. So we can say to them, what we're looking at are some of the issues that might get in the way for you that could have that we could have together or you could have prevented happening. And, in the beginning of the presentation, I talked about the fact it's pretty complex. It's not like it's an easy picture. Certainly somebody who's scheduled to have treatment, because they couldn't have all the treatment because they were too weak, that's an unavoidable readmission. Those are fine. So what we want to stop are the ones that don't have to happen because, again, we know that people do not want to go back into the hospital. They want to be at home.
Okay. Amy, where do you see telehealth helping to reduce readmissions?
Well, it can be very useful, I think, if people can use that as a way to gather information. Again, I think what we said is it's useful for the patient and the family to know whom they're supposed to call when they leave the hospital if there is an issue. Who's their contact point, especially if they've had a team of people caring for them. I think this is enormously confusing. But certainly by calling telehealth, what they can do is talk about symptoms they're having, issues they're having, and telehealth can help assess whether or not it's necessary to go to the hospital, or is there perhaps another solution, if it's not an emergency, could they go see the family doctor in a couple days? Whatever that situation is, they can help provide that kind of information.
Okay. As always, we like to share tips and resources that our attendees sent in, and here's one of those. Regarding the resource list, another excellent resource is the National Transitions of Care Coalition, a nonprofit interdisciplinary cross-sector coalition that's been working to improve transitions of care. NTOCC has multiple resources, all free of charge, tailored towards different audiences, parents, family caregivers, healthcare professionals, the media, et cetera. And the URL for that is ntocc.org. Again, ntocc.org. So
that's a fabulous resource, and thanks to whomever shared that. Excellent resource.
Yeah, definitely a great resource.
Yes.
Again, ntocc.org if you want to go check out that resource. Next question here. Do you feel that perhaps simple video communication between care partners, such as medical, family, home care, et cetera, and the patient would help to avoid some of the problems that are currently experienced?
I do. I think we're going to see more of that in the future. Right now it's not as widely available as we would perhaps like, but there certainly are pockets where it's available, and I think it can be very, very useful for people. We know again that this can be useful for doctors to even be able to assess what's going on with a patient while they're at home. You get to see the person. So there's a lot of ways I think that a lot of our technology will shift in the future in a way, and is already shifting. It's just not as widely available again as we would like. But there are ways that I think that will make a huge difference in people being readmitted. And I think, again, back to my own parents, and if that had been available, there were a number of times my mother ended up going to the emergency room and ended up admitted because she was having symptoms. She'd had a stroke and was quite disabled, and it appeared she might have had another stroke. And in actuality, it was urinary tract infections each time. And the first few times it happened, my father immediately took her to the emergency room. And in the future, after, of course, he got better educated, he knew to first have her urine checked because it was so consistently that issue. And I think had he been able to communicate with a doctor, or a doctor been able to look at what was going on, that might not have happened. So I think we can look at lots of situations where people probably go back to the hospital, whereas if they had the technological advantage of being able to communicate in various ways with healthcare professionals, they wouldn't need to.
Okay, and a couple more comments here from our attendees. I like that you made the statement, if it's a safety issue, it's okay to override. I say this frequently to caregivers, and it's important for them to understand the urgent need to override when a safety factor is present. Thanks for saying that.
Well, thank you for saying that, and I do, because it sounds like you've had this experience, as I have, in watching where people have said, well, they didn't want me to call 911, so I didn't do it. And you're thinking, oh my gosh, how could you not have done that? But, people can be pretty determined to not have 911 called. And I think, one of the issues we know about calling 911 that people sometimes have is that they don't want to disturb their neighbors with the sound of the ambulance. They don't want to be embarrassed that they called 911 and it wasn't necessary. And so I think the more we as professionals reinforce, call 911 even if you think you could be wrong, it's a much better way to go. And certainly with family members, we have to encourage them to override that decision when often it is based on embarrassment or not wanting to disturb anybody. I had a very hard time getting my father to use the emergency response system that he had in the house, and he spent a couple of nights sitting up in a chair in the living room, sweating profusely, very ill. And I'd say, Dad, why didn't you just press the button? And he said, I didn't want to disturb anybody, And I'd say, well, that's why it's there. That's why we have it in the house. But it was very difficult. And at that point, he was living alone. Had I been in the house with him, I would have overridden that and called 911. So I think, again, we have to encourage family members to be proactive and to recognize that they could save the person's life or certainly improve an outcome if they do call 911.
Okay, next question. Are there provisions for patients who have no family or who live alone and have no means to pay for a private caregiver to help them after discharge? Who is advocating for these folks?
I wish maybe somebody on the call can answer that better than I can, who's on this webinar, because the resources aren't always very good, and there are often pretty significant gaps. And hopefully, discharge planners are working with the person to make sure that there's a safe situation they're coming back to. But often, as you heard in the report, these are the people who end up getting readmitted. So we can see there's a gap just by looking at the report. They said, older men who were divorced or living alone were very likely to end up coming back because they didn't have the proper care. So again, I encourage anybody on the call to write a comment if there's a great resource that you can give on this.
And somebody did just that, wrote in and said, contact your local area agency on aging.
Yes, the area agency on aging is always the go-to place for services. You know, I was looking for something, just curious if there was something more specific people could recommend, but absolutely the area agency on aging. The other generic resource, of course, is the adult services unit of your Department of Social Services. If somebody qualifies for help, they can also intervene at that point.
Okay, another comment here, and the comment is, you're so right about medications being a problem. It seems that a hospital stay nearly always involves changing prescription medications for seniors. This can really be a problem when discharged because there's no follow-up on the side effects of the new drugs, which are often more pronounced in seniors due to decreased kidney function that is common with aging. They may end up being readmitted just because of these drug side effects. Do you have anything to add to that, Amy?
I do. I think this is, again, why it's so important that people have a follow-up visit with a healthcare professional, whether it's their doctor, you know, whether it's a nurse practitioner, whomever, because, and that there is better communication around the drugs that are prescribed while in the hospital, so that the doctor absolutely has a list of those as well. In the case I mentioned during the webinar, you know, where there was the interaction, the person's doctor didn't even know the person had been put on that drug. There was no communication at all. And so, you know, when that interaction occurred, they were as shocked as the patient was. So I think it's kind of unfortunately a multi-layered problem. It's this idea of communication, and it's also an idea of follow-up medical care to make sure that the person gets to see someone quickly who also has been informed about what the changes have been made. Because I agree, I think almost always there's a medication change that occurs when someone's in the hospital.
Okay, and actually a couple great more suggestions coming in. I'm just going to bang through these really quick here. Suggestion for caregivers, find out if there is a PACE organization in your area, and PACE stands for Program of All-Inclusive Care for the Elderly. Let's see.
And that's a great program, and I just want to say, Steve, that they are all over the country. They're fabulous programs. I just wish we had more of them.
Okay. Another suggestion is a new startup called Bright Life Innovations is working on a solution for senior patients who don't have family members to help them out. So again, that's PACE, Program of All-Inclusive Care for the Elderly, and Bright Life Innovations, which are two potential resources. And also,
I'm not familiar with Bright Life, so that's I'm glad to hear about that myself.
Yeah, it's great to be getting these resources in.
These are fabulous. Yep.
Yeah, if you're a veteran or if you're a surviving spouse of a veteran who needs home care, I would recommend they check the aid and attendance program to see if you qualify. And there's also a suggestion, find out available, check your local area, not just the national ones, because again, there's a differentiation between those two.
That's a fabulous resource, and you know, I often forget to mention veterans resources, and I think thank you to whomever said that, because often there are great resources for veterans, you know, on these things, and I think you know, we're dealing, as you know, with a very expensive issue when people come home and they're dealing with all of this. So I think the fact that any resource we can get to help people reduce those costs are really key.
Okay, next question. I'm running into an issue where individuals are going to the ER and being put under observation for 3 to 4 days. They think they're being admitted, but they don't realize they aren't until they get billed differently than they would be or having been admitted. Is this the hospital's way of keeping the readmission rate down?
I don't know the answer to that, so I don't want to say negative things about the hospital as a, you know, in response to that. I truly don't know, so that's why I'm not offering an opinion on that. I do see it as a problem. Whether it's a way to keep hospital readmission down, it may be, you know, where that policy come from. And again, somebody on the call may have an opinion on that, but it's certainly a problem because, as you say, people get billed differently, and they may be quite shocked by that. So I think this is another opportunity. What you're saying here is another opportunity for us as professionals to talk to families and patients about making sure if they do go to the hospital, they understand whether they're under observation or are they actually being admitted, what's happening there.
Okay, and another resource, I also recommend geriatric care managers to the individuals and the families who may live far away and are unable to travel to care for elderly parents. So
Absolutely. I love geriatric care managers. You know, some of the issue for many people that we deal with is they can't afford to privately pay for something. But for people who can, geriatric care managers can be an absolute godsend. And this is one of those areas where they certainly can be, because we often have, you know, adult children living on one side of the country and their aging parents on the other. And to have somebody that you know is consistently in there and can monitor the situation and, you know, be a point person can be fabulous. And, you know, that's why the recommendation of home care as well. They can play that role for people in a different way, not in the exact same way as geriatric care managers. But thank you for throwing that in, because geriatric care managers are fabulous.
Okay, Amy, this next one is a biggie. The question is what to do if mom or dad is not compliant?
Not compliant with the discharge plans. I'm assuming that's the issue we're talking about here, that they say, no, I won't do it.
Yeah.
You know, this is a tough one. There's no simple solution to this either, as you may guess. There's various ways to approach it. And, you know, and if you've been on calls with me before, you know that I say this frequently because it's how I approach thinking about how to deal with issues. That my thought is always, if you think about possible interventions into any issue, that they run along a continuum from least intrusive to most intrusive. And that I always advocate on starting on the side of least intrusive and seeing if you can make an impact there. Because if you start there, you can always increase what you do. But sometimes I think we have family caregivers who come in like gangbusters, right? They just come in and often are too heavy-handed. So, you know, starting in a place that's a little less heavy-handed is better in my view, because we want to treat our aging relatives with dignity, respect. We want to continue to let them have autonomy, obviously, not let them have autonomy, encourage their autonomy, and see them as the people that they are. And so I know that when families come in very heavy-handed, it comes from a place of fear a lot of times, or frustration. So I think as professionals, we can help with that. So in the case of noncompliance, that was a general statement to get to this, is I think you can start by having a conversation with the person about what the implications are for not complying, which means that the caregiver has to get that. So let's say the person starts smoking again or doesn't use their insulin. You know, having a calm conversation about what the implications are and what could happen is a very very lowly intrusive intervention. Now, that may not make any impression at all. A next step up that to me is kind of go more on that end is to talk about how the caregiver themselves feels about what will likely happen if the person doesn't comply with this, and obviously the consequences were talked about before, but how it impacts them. And the reason I say that is a lot of times I have found that people will do things for someone they love that they won't do for them. So I've seen people give up smoking, make major life changes because their spouse or child said, this impacts me so negatively in this way, and I love you. And the person says, wow, that made an impression, I'll do it. That's the next step. Obviously, you can try to engage the person's healthcare provider in this dialogue. That's another step. And ultimately, again, I'm assuming no safety issue here. If there's a safety issue, you have to intervene, obviously. And I mean a clear-cut safety issue. But here's the hard part about this. We are all autonomous beings who have a right to make decisions that other people don't like, and that is true of older people as well. And I often will ask people who are caregivers who say, but I want my parent to do this. And I'll say, have you ever made a bad decision in your life? And everybody laughs because, of course, we all have. And I say, we have to remember people do have the right to do that. But when safety is involved, we have to intervene. But otherwise, people have a right to make decisions we may not agree with and like, and we can intervene to the best of our ability. And then at some point, we have to recognize their right to do that.
And Amy, we are just about out of time today, but I want to thank you for another great presentation. Thank you.
Thanks, Steve. And I want to thank everybody who did write in, because they made it a much richer presentation with their comments. So thank you for that, and I hope you'll continue to do that in future webinars.